Hi, everyone. Welcome to the Altmed podcast. With me today, as always, Mitch Kurtz, my co-host. And we have
Hello.
a hello, Mitch. We have a very special guest today. We have from Mind Medicine Australia, the chairman himself. It is Peter Hunt. Peter, welcome to the podcast.
Thank you very much. It's nice to be doing this with you.
It's a pleasure having you.
And of all the days that we could be doing this, it is the day that a report that was commissioned by the TGA has been handed down, which I guess probably, for want of a better term, just vindicates a lot of the work that your organization, Mind Medicine, has been doing in the field of psychedelic medicine. So we're very lucky to have the opportunity to talk to you of all days on today. So before we dive into that and talk about maybe a bit of a 101 around psychedelic medicine, can we perhaps start with your personal story, which was actually published on Mind Medicine's website back in June. And I read that and it really did move me. It's just such an intriguing journey of how you managed to find your way toward psychedelic medicine. So I'm going to hand to you and then we can start to unpack the 101 basics.
Yeah, okay. Well, by way of background, I grew up in England, the first 13 years of my life. Pretty traditional family, what I regarded as a pretty loving family. And then with no notice at all, my father committed suicide. And because he'd gone bankrupt, he basically left my mother with nothing. My mother was courageous enough to say, because we had nothing, let's start again and move to Australia. And so I came out here as a young man, then 14, and arrived in Australia. And with mixed feelings, I've got to say, excitement, but also great sadness about leaving everything I'd known behind. Immersed myself in education, which was quite uncharacteristic of me, but I think it was the impact of what happened to my father. Did much better at school than I ever thought possible. Then went to university, then became a lawyer, then moved into investment banking. And frankly, kept surprising myself in terms of how well I did. But as I grew older, something was missing, and what was missing was community, and the fact that I'd been pretty lucky because I'd come to Australia because of an amazing mother, and I could so easily have spiraled down, and that led me into the not-for-profit sector after 30 years of investment banking. And between my wife and myself, we've started now 5 charities, of which Mind Medicine is the 5th. So that's the background. In terms of psychedelics, I have to admit that as a young man, I didn't go anywhere near anything that had the word drug in front of it.
Yeah.
So I had this sort of thought that actually, and it's in the case of these psychedelics, completely misguided, that somehow it would wreck my brain or it would be addictive. So never did anything other than, drank some alcohol as a young man. My wife, Tanya, then came across an article in the New Yorker by Michael Pollan about a really amazing trial done by New York University for people with end-of-life distress. They've been told they've had a terminal illness and were pretty depressed about it, not surprisingly. They'd given them psilocybin-assisted therapy, and extraordinarily, those people came out of that experience with wonder and at peace with the dying process, which is a pretty amazing gift. And one of those people was a Jewish Holocaust survivor.
Oh.
Now, my wife is Jewish, and like all Jewish people, I think there's intergenerational trauma because of what happened to them in the war. And she got fascinated by this psychedelic therapy and tried to get us on trials. Got on really well with the researchers in London. But the net effect of that was that we couldn't get onto a trial because we don't have any obvious mental illness. So we then went to Holland, and where it's legal, and Tanya organised a therapist so that we could try psilocybin. And I got to say that I didn't think much about it. I had a lot of confidence in Tanya. She wanted to do it. And so I went along with it. And I found the experience quite extraordinary and not what I'd expected. And I came out of that experience really feeling that this was something incredibly special. Didn't do it for another 12 months, which again sort of indicates or should indicate that this stuff isn't addictive. Did it a second time, and then Tanya and I both came out of that experience saying, hey, we've got to bring this to Australia. We've got to make these therapies available to people suffering from mental illness, because they can offer an enormous opportunity for people suffering to get well.
Yeah.
So that's the story in brief.
Oh, it's amazing. Did you find, I mean, just going through that, that experience, obviously supervised in that clinical context, but, in terms of, did you have any idea of whether the dose that they had given you was, I guess, fairly modest, or, did you, I guess, I think you recalled in the article that you had started seeing shapes and things like that. So I'm guessing it was perhaps maybe a little more than modest.
And it was definitely a breakthrough dose.
Yeah.
And the therapists that we had understood doses. And it's a strange experience because, when you start, nothing happens for about 20 minutes. And my reaction in that 20 minutes was, well, what's the big deal? And, you're lying there and you've got eye shades on. Suddenly you see these extraordinary psychedelic shapes. And that's sort of interesting. Yeah. But then suddenly you're sort of whizzed off into a completely different dimension of consciousness. Yeah. Where you become the observer. And it's fascinating because the ego is gone and you're literally in your mind just observing sensations coming into the mind. And it's no wonder that people come out of that experience feeling connected because during that experience, you feel connected with everything. It's not what I'd expected, by the way. I mean, I'd expected something which was all the stuff you sort of hear about in terms of drugs and all that sort of stuff. Wasn't like any of that. It was an extraordinary experience.
Yeah. What is that exactly that that you think people think of when they think illicit substances per se? Like, what kind of image does that conjure for you?
Well, not now, by the way, but I think if I was being honest about myself in younger days, it would have been, people weren't being responsible. They were trying to escape from reality, all those sorts of bias that so many people have. But when it comes to these psychedelic medicines, I mean, firstly, all the evidence says, even in a recreational environment, they are very safe. And there's been all sorts of university studies confirming that. Yeah. When you bring them into a medical domain, they're incredibly safe. Yeah. And they're not addictive. And the remission rates that they're getting in trials are somewhere between 60 and 80%, which is for depression and PTSD, which is frankly unheard of with current treatments.
Yeah, it's amazing. And I think just the contrast between thinking about, you in Holland with your wife with on versus how many people in Australia might have had their sort of first experience because of the fact that it is kind of bundled with that recreational for hopefully not too much longer, which we might as well dive into the report. Actually, before we do, I think Mitch flagged before we talked that we should get a 101 basics of psychedelic medicine on the table.
Well, I think it's just worth noting, just so people who might not be familiar with, for example, the types of medicines that we're dealing with when we're talking about psychedelic substances.
Yeah, and the conditions that they treat as well.
Yeah, just as an overview.
Yeah. Well, I mean, quick overview. If you think about mental illness in Australia, we have some of the worst mental health stats in the world. In fact, on a per person basis, we're second only to Iceland. Pre-COVID, 1 in 5 of us has a mental illness. 1 in 8 of us are on antidepressants, 1 in 4 older people, 1 in 30 younger people. PTSD, when you look at the treatments work for many people, but they don't work for a large number of other people. So, with post-traumatic stress disorder, you've got remission rates of somewhere below 10%. With depression, remission rates of about 35%. So there's a large number of Australians who suffer from mental illness and never have the opportunity of getting well. And that means their lives aren't the lives that they should have. You then look at innovation in the sector, and there's been precious little innovation now for decades. Probably 40 to 50 years in terms of pharmaceutical innovation. Now, turning to psychedelic assisted therapies, they were used a lot in the 50s, in the 50s and 60s, before Nixon started his war on drugs and psychedelic medicines got caught up in all of that. But the way it works is this. You first screen to make sure that these therapies are appropriate for you. And to date, they've been primarily used for treatment-resistant depression, that's psilocybin, or PTSD, which is MDMA. If you get through the screening, you'll then spend a bit of time with your therapist, talking about your background, but not getting into the trauma or the events that cause the mental illness too much. It's really a chance to get to know your therapists and get comfortable with them. And then comes medicine day, and you'll go into a room which is decked out to feel really comfortable. So there'll be some sort of lounge there which you can lie on. You're given eye shades. Music is played, and you're made to feel as comfortable as you can be, given that you know you're going to take this tablet, which is going to have a significant effect on you. But at that stage, you've got confidence in your therapists, and they're going to look after you, and that safety feeling is really important.
It's the rapport.
It's the rapport. You then go through the medicine experience, and we might come on to it later, but the psilocybin experience and MDMA experience, they're fundamentally different. At the end of that experience, you go through what's called integration. And the purpose of integration with your therapist is to really bring out what you've experienced in the medicine sessions into your life so that they can be retained afterwards. You'll then go through another medicine session, and you'll have another integration session after that. And you may have a third medicine session and a third integration session. But the beauty of all this is that after these 2 to 3 sessions with the medicines and the integration that's framed around that, that's it. So we're not talking about taking pills for year after year after year. We're talking about a short course of therapy at maximum of 3 dosing sessions. And as I say, remission rates for people with treatment-resistant depression and PTSD of somewhere between 60 and 80%, which is truly remarkable.
Absolutely. When you think about those people potentially otherwise being committed to a lifelong cocktail of various, SSRI and other antidepressant medications. One thing you said that I just have to ask about. Do you know is there a playlist that's established for these types of sessions? What kind of music do they put on?
Well, no, the playlists are very carefully put together to make sure they fit in with the medicine dosing that you're going through.
So it's Jimi Hendrix for psilocybin and it's trance music for MDMA. Is that?
No. I mean, the playlists have come a long way since the early days, and what they're trying to do is, in the early stages of the experience, it's music without many words or no words, because the last thing you want to do is get the patient to start thinking about the words.
Yeah.
The music's designed to bring out the experience. Later in the playlist, you may have music with words, but what they're trying to do is they're trying to use the music to actually back up the experience you're going through. So as you go to a peak, you want the music to go to a peak. As you start to come down, you want a different type of music, and it's very clever.
Does that tie into also, reports of people experiencing synesthesia, for example, in those moments?
Well, it can do, because one of the extraordinary things about these the medicine dosing sessions is, as I was saying, you become with psilocybin an observer, and you don't have control of your senses. So it's no wonder that the senses can become a bit different to what we'd normally experience in ordinary life. But that's part of the wonder of the whole thing.
Yeah. And does it stop? So psilocybin, MDMA, the other types of drugs that you're looking at, LSD?
Not so much. I mean, the reason we haven't focused on LSD is there are connotations with LSD in people's minds, which I think makes the hurdle a bit higher in terms of getting broad public acceptance. And it's just
Really?
it's just
Sorry, I was going to say higher than MDMA.
definitely higher than psilocybin. And LSD and psilocybin have a lot of commonality about them. MDMA is quite different.
Yeah.
But MDMA, one of the things that we talk about a lot is that people need to stop confusing medical grade MDMA with ecstasy. Ecstasy, a street drug.
Yeah.
With ecstasy, there are almost inevitably adulterants. It's not pure MDMA. There may actually be no MDMA in it at all. With medical grade MDMA, we're talking about pure GMP standard medicine without any adulterants at doses that are safe. It's very different from going to a rave club and getting hot and excited, drinking some alcohol, then having the ecstasy, not really knowing what the dosage is, getting it off the black market, not knowing its purity, and getting adverse consequences from that.
So I'm just so amazed that we're talking today of all days, and the report and I only skimmed it before, but basically for those tuning in, the TGA commissioned a report to be done, and please jump in, Peter, if I'm messing any of this up. But basically, the report, it's quite in contrast to what we saw earlier this year when the TGA handed a sort of an interim decision saying, we're actually going to keep MDMA and psilocybin as Schedule 9 controlled drugs. Prohibited substances. We won't move them to Schedule 8 controlled. And the report examined, I think there were 8 trials, 6 of which related to patients with PTSD, 1 related to anxiety and people who had, I think, suffering from a life-threatening illness. And then there was anxiety from adults with autism. And I suppose I think across the board, there were really favorable results to both psilocybin and MDMA, but particularly I read for MDMA in doses of 100 milligrams or more. But now the commentary has kind of moved to, well, it's inevitable that the TGA might now just in the next sort of few months actually improve access pathways by bringing it from Schedule 9 to Schedule 8. How did you kind of digest the report? I'm sure it's been a busy afternoon for you.
Yeah, well, just to sort of go back about some of the history, we put in an application to reschedule these medicines back in July of last year. It was in a public consultation period where like 96% of all submissions were in favour, and half of those came from the health sector participants, so very strong support. You then had a negative interim decision in February. We responded to that by going through every one of the arguments that were used in a lot of detail, in quite thick documents, all of which were highly analytical documents. Net result of all of that was that the TGA then decided that actually the best thing to do would be to get the advice of an independent panel, and all credit to them, by the way, for doing that. That panel came out with its report today, and the great thing about that report is that they're saying 2 things. Firstly, these medicines, when they're used as part of therapy in clinically controlled environments, have high safety levels. So that should take off the table this issue of are they safe or not. And the second thing they say is that when you look at trial results, the trial results are statistically significant in terms of these therapies being able to generate remissions or significant results in patients suffering from treatment-resistant conditions. So, those 2 factors, safety and efficacy, should enable the TGA now to reschedule these medicines from Schedule 9 to Schedule 8. And that will be something that, that's a really exciting development. And I say that because at the moment what's happening is that if a patient's treatment resistant and the psychiatrist believes that MDMA therapy or psilocybin therapy is the best treatment, and the patient gives informed consent to that, the psychiatrist with a Schedule 9 medicine can still apply to the TGA for approval to use the medicine. And psychiatrists have been doing that with MDMA and psilocybin, and every time they do, they get the approval of the TGA. But the problem in Australia is this state system we have. And for a psychiatrist to use the medicine, you also need state government approval. And in Australia, there are no permit mechanisms for state government to give their approval to a Schedule 9 medicine other than in Victoria. So the beauty of moving to Schedule 8 is, firstly, for the first time, they're recognised as medicines because they're controlled medicines. But secondly, it opens up patient access gateways right across Australia. So it follows the route that cannabis went. And that's really exciting.
It's absolutely is. And I think, I mean, one of the other things that I know it will be small steps in this space, but well, first of all, actually, let me just say thank you so much for putting in a submission to that interim decision and addressing all of those points in turn. I'm interested in your thoughts around the fact that the barriers that might exist for a patient is this idea around treatment resistance. And you saw the same thing with cannabis, where effectively to be approved, you had to have failed at a first line therapy.
Yep.
What are your thoughts around that? Because I imagine there's probably some people who, you know, maybe don't meet that high threshold for access to these, but are actually just interested in undergoing and are prepared to pay for a clinically supervised psychedelic experience. So yeah, I'm just interested in your thoughts around that barrier.
Yeah. Look, the reason we started with treatment resistant patients is by definition, the current medical system's not actually helping those people to get well. So there is a need for innovation. And there's also now a lot of trial data supporting the fact that these therapies are safe and effective when used in medically controlled environments. So for us, that seemed to be the easiest hurdle to cross. Now, when I say easiest, I'm using that term carefully because there's a lot of bias, or there has been a lot of bias against these substances. So we've had to do a lot of work to make people aware of the fact that all the data, the science and the data does show them to be safe and effective. I think the benefit of opening up this for treatment-resistant patients is, firstly, they're obviously the people who are most suffering in our society and need these therapies. But once they become part of the treatment paradigm for people who are treatment-resistant, and the medical system and regulators and the public generally get more and more comfortable because they see the results, then I think the next stage is what you're talking about, that anyone with depression or anyone with PTSD will have this as an alternative to other therapies. And between that person and their doctor, they'll choose the treatment option that most suits them. So if they want psilocybin-assisted therapy as a first-line treatment, well, that will be available. But I think that will only happen when the medical system gets comfortable that the therapies are working with treatment-resistant patients. Now, the third stage is again the one that you're suggesting. If these treatments work effectively with people who are both treatment-resistant with depression or PTSD and first-line people with PTSD and depression, why can't they be opened up to anybody who would like the experience, but in a proper clinically controlled environment? And I hope ultimately that will happen. But, you know, if you try to get there straight away, I think it's a bridge too far. But if you do it in steps, then I think it's possible over time. And let's not forget that, you know, the third one I mentioned, this being available in clinical environments, is what happens in Holland. And in Holland, the world hasn't fallen apart.
So basically, you're saying it's the low-hanging fruit of a use case to get your foot in the door, essentially.
Get your foot in the door, but also, you know, provide these therapies to the people who need them most. Yeah. And they're the ones who are deeply suffering because nothing else is working for them in terms of treatments.
But did I hear correctly in hearing you say that patients would almost have the option as to which one they'd prefer to try? Is that the way? It would not be kind of decided by the medical practitioner. Maybe you're not suitable for MDMA, but you are suitable for psilocybin, for example.
Well, I think in the first stage, as I say, is treatment resistant. And you've got to get through that stage first and get everyone comfortable that it's working and it's safe when it goes out to clinical practice, and the right protocols are in place. But over time, as people get more and more comfortable in the system, the second stage, as I say, will be opening it up to non-treatment resistant. In other words, people with depression who may have not gone onto antidepressants, may have not done conventional therapy, but for whatever reason, believe that psychedelic therapy is the best thing for them. But you don't get to that stage 2 unless you've gone through stage 1 and everyone's comfortable with stage 1.
Yeah.
And I'm a great believer, you've got to push the system a bit, but don't push it too hard.
Yeah.
Because if you push too hard, it's likely to push back at you.
Yeah.
And we don't want to see that happen.
So is there potentially a stage 4, which I heard you kind of loosely alluding to earlier about safe in recreational settings as well?
Is this a personal inquiry, Mitch, or is this a sort of an inquiry?
Well, sometimes you just don't feel like a beer. You know what I mean?
Well, that's my stage. That's my stage 3, actually. I mean,
that's your stage 3.
Yes. And I would hope that Australia will get to that position, but I don't think we should try and push that position until people get comfortable with its use in a medical environment for people with mental illness.
Oh, I was meaning a non-clinical environment. So clinical products outside of a clinical environment, and in the same way that you would, have access to alcohol or potentially marijuana in Canada, for example.
Yeah. Well, that's stage 4. I think that's a big jump.
Yeah, I agree.
We shouldn't forget that, these medicines are powerful, and I think they need to be respected.
No, absolutely.
Yeah, and I'm not suggesting, by the way, that people in a recreational environment may or may not respect them, because many people, I think, who take them recreationally do respect them. But I just think we have to be careful and do it step by step. Yeah.
Yeah, no, I agree. I just meant from a feasibility. Do you think that's even, 50 years from now, something that you could imagine? No, I'm kind of just.
Well, I'd actually hope it will get to that stage, but I say that because you go to Holland, and in Holland you can go into a shop which sells psychedelic medicines, and you can buy them, and you can then go into a park or you're back to your home and take the medicine. And Holland is a civilized country. The system hasn't broken down because people are taking psychedelics.
Yeah, they're called truffles in Amsterdam.
They're called truffles, yeah. So, I mean, I would hope it gets to that, but I think it needs to be done step by step, so people are taken along the journey and feel comfortable.
Yeah, I think it's interesting you talking about the I guess the extent to which the medical community begins to really sharpen its focus toward the utility of these amazing medicines for some people. And in my previous job, I know you mentioned you're a lawyer previously. I was actually a lawyer at a big firm and went along to support the Royal Commission into Mental Health in Victoria, into our system here, and just hearing so much evidence from so many brave people, including actually Andrew Robb, who I saw is coming to your summit, which we'll talk about soon as well. But I was really just what really came out of that for me was, I guess, as you said, mental illness is so prevalent in Australia, and we seem to have this system that is responsive to people who need acute care, but everyone else before that is kind of really just seeing their GP, getting a script for some sort of antidepressant medication. And for so many, as we've been talking about them, they're treatment resistant. So to me, I can't think of a medicine where there's so much incentive really for people to at least try it, so that we can begin to actually, it just seems like there's just such an overwhelming case for people to trial this, given the statistics that we see around mental illness. Is your sense that it's not actually going to be that difficult to sell? Or do you still think there's actually quite a bit of reluctance from many in the medical community toward trying these particular medicines?
I think there's less reluctance now than there was 2 to 3 years ago. But, often it's because a doctor or a health practitioner hasn't actually looked at the facts. And I'm not discourteous when I say that, because our health practitioners have an enormous burden in terms of workload. So it's, to ask them to keep reading new stuff,
Yeah,
it's a heavy burden for them. But to give you one example, we did a presentation at a medical clinic, a large medical clinic, full of doctors. And they invited patients of the clinic to the presentation, and they have a psychiatrist on site. And the psychiatrist came into the presentation, and the first thing he said to Tanya and me was, "You got to be joking. You got to be joking that we're going to be using psychedelics for mental illness." we then took him through the presentation, and we had a professor of psychiatry in the presentation team. And at the end of the presentation, that same psychiatrist who'd been so negative came up to us and said, "Listen, how do I offer this to my patients?"
wow.
And it's classic, when people go up the learning curve and they see that actually the data and the science supports this and it can be used safely, they get on board. But it's a message that every week we're out there talking to medical practitioners to get them up the learning curve.
Yeah, big education piece involved.
Huge, and same with regulators and politicians.
I've got a query on that, because obviously I'm thinking about the psychiatrist's position before and thinking maybe he's seen drug-induced trauma, for example, come through his clinic. I'm wondering, would alternative or psychedelics, alternative medicines, treat drug-induced trauma as well?
When you say drug-induced trauma, I mean,
I
think it's the other way around, that often people can get addicted to drugs, whether it's alcohol or something else, because they suffer trauma. And the way they're dealing with that trauma is to take these substances that make them feel good, at least for a short period of time.
Sorry, what I meant was that I know I've heard of some people, for example, anecdotally, have had psychedelic-based bad trips, taking too much, not clinical, don't know what's in it to some degree. But I'm just wondering if the same drug could be used to treat that type of experience, if that makes sense.
I mean, the answer is yes, but again, Tanya and I don't pretend to be medical people, and
fair enough.
Patients need to be screened properly by the psychiatrist in that circumstance,
sure,
to make sure it's appropriate for them. I should also say that, by the way, one of the concerns of the recreational scene is just what you've talked about. One of the groups that's screened out of these therapies are people that suffer psychosis. And the reason they're screened out is, if you already suffer psychosis and you go through one of these experiences, your psychosis could get worse. Now, in an unregulated environment, if people with psychosis start taking these, what are quite powerful medicines, that could be damaging to them. So, I think we've got to recognize that these are powerful substances, and they need to be utilized in a controlled environment.
Absolutely. Yeah. And I think, I mean, it's also because you talked about before, there's, almost like a 50-year gap in research. We know that they're powerful, but there's also just so much that we don't know, and so much clinical research that's being done. I saw that, I think a few months ago, there was an announcement about, I think the company is called, or the organization is called Psyche, and they are opening a $40 million research facility in Melbourne. Are you where do you see that research landscape? Do you feel like you talked before about how we know enough to know that these medicines are safe, but do you feel like there's still just such an enormous amount of research, or do you think we're actually in a pretty good position to know what certain doses do for certain medical conditions?
Oh, I think in terms of dosing, we're past that. We sort of understand what are the appropriate doses with psilocybin and MDMA. And I think we've now passed the issue of, are they safe to use in clinically controlled environments, because we know they are, and that's what that independent report basically confirmed today. And I think from the trial results, we know that they can generate, with appropriate therapy, really high remission rates. So all that's positive. So in terms of further research, to me, we've got to a stage where these should be available in the right circumstances with the right trained professionals in clinical environments. But there's always a need for further research. And that's true, by the way, of any medicine. And in this case, what could the research cover? It could cover different ways of providing the therapy. Is one particular way of providing the therapy better in terms of lasting remission rates? It could cover applying these therapies to different mental illnesses, which haven't yet been addressed. And there's a lot of work starting with things like eating disorders, work starting with dementia, some really interesting early work. And there's also research, I think, required for other psychedelics, like DMT, like ibogaine, which are in earlier stages of their development. But in terms of psilocybin and MDMA, let's get it out there in clinical environments which are properly controlled to enable psychiatrists and their patients who want to use these therapies to be able to use them and have the chance of getting well.
Yeah, and there just must be so many Australians who would meet that eligibility criteria around treatment resistance. The more I'm sort of thinking about it, I mean, yeah, the numbers of people that will hopefully soon have access to these, but then of course, do we have a shortage of clinics that have appropriately trained staff to be able to do a supervised experience? I suppose that is something that might need further education. Is there a shortage there, do you think?
There's definitely a shortage, but again, what we've done at Mind Medicine Australia is we've started a clinical training program. The first intake was February this year. That was about, I think, 46 psychiatrists, psychologists, and other health practitioners. The second intake is currently going through. So by the end of this year, we're going to have 90 trained professionals. Next year, we're aiming for 4 courses, so another 200 trained professionals.
Wow. And
each year it's going to double or treble. So the aim there is to actually make sure we do have the right clinicians properly trained with the right supervision in place. When you look at our faculty, it really is world's best practice. We have leaders from around the world teaching on the course. We have 2 extraordinary course leaders who are absolutely fabulous. One a psychologist, the other one a psychotherapist. And the testimonials we're getting from medical practitioners who go through the course are fabulous. They're talking about this being the best course they've ever done.
Wow.
A lot of work's gone into making sure that people are properly trained.
That's great.
At the same time, we've been designing with clinicians proper protocols to be used in clinical environments and everything that goes around screening and so forth to make sure that these therapies can be used safely.
It's just a strange question that popped into my mind. Are these does it have to be one or the other? Is it possible for somebody to actually embark on a clinically supervised experience with both MDMA and psilocybin, or is that just being a bit greedy?
I mean, there's not a lot of research into that, and it's not something that we're going to put forward. One thing might just be worth explaining is that the dosing effects of psilocybin and MDMA are fundamentally different. Shall I go into that for a...
Yeah, absolutely. I think that's definite value in that.
Yeah. With psilocybin that's used for depression, when you take the medicine as we did in Holland those years ago, I mean, you literally get transported into another world where you become an observer and you have no control of the information coming into you, the sensory information coming into you. And it really, if it's done in the right way, can be quite an extraordinary experience. And people invariably come out of that experience feeling incredibly connected. Now, when you think of depression, one definition of depression is disconnection. I've got no friends, I've got no future, no one loves me, I feel miserable. It's disconnection. So, you come out of the experience as a person with depression feeling incredibly connected. And the task then of the therapist in integration is to enable you to take that feeling of connection back into your everyday life And that's when remission happens. With a psilocybin experience, you're literally in another world or another state of consciousness, and you're not going to have a lot of conversation with your therapists. They're fundamentally there to make sure you feel safe. And if you start to get nervous or whatever, they're there to basically make sure you get more comfortable.
Yeah.
And by the way, there'll be discussion before the dosing session about what happens if you start to go into a bad place. And what the therapist will often say to you is, if you start going into a bad place, literally walk towards it. And that's happened to me, by the way, in the psychedelic experience.
It's interesting.
And the amazing thing that happens when you walk towards it in your mind is it just evaporates. And isn't that an extraordinary lesson for somebody, that actually all these things that bring you down, many of them are just imaginary. And if you confront them, they just go away. So that's psilocybin. MDMA is different because with MDMA, with psilocybin, you and I wouldn't be having an intellectual conversation. We'd both be in another world if we had both taken the psilocybin. With MDMA, you're still capable of having a very rational conversation with your therapist. But the beauty of MDMA is it's an empathic medicine. It makes you feel secure. Sounds a bit weird, but it makes you feel very loving. And it's in that environment that the therapist can start talking to the person about what happened to them that caused the trauma. Now, the reason that's so important is that normally what happens with somebody with PTSD is they go for therapy, and what the therapist is trying to do is get them to talk about the events that caused the trauma, a car crash, abuse, whatever it is. The problem with that is that often a person with PTSD, as they get closer to talking about what happened to them, the fight or flight response comes in and they get triggered. And that's quite dangerous, because they start to imagine all the things that they experienced at the time of the trauma. The beauty about MDMA is because the patient feels safe, they can approach talking about the trauma in a way that doesn't trigger them. And that means their last experience of thinking about the trauma was being able to talk about it in an environment where they felt safe. And once you do that, that's the staging post to start getting well. So that they're fundamentally different, and that's why MDMA is primarily used for trauma and psilocybin for depression.
Yeah, the oxytocin kind of binds them to the people they're talking to.
Yeah, I mean, it really is an incredibly amazing medicine. And the beauty of both of these therapies is they're curative. They're not palliative. Antidepressants tend to be palliative. What they're trying to do is smother the problem. But they smother it often at a cost, and the cost can be adverse side effects, or it can be stifling the joy of life. You're taking away some of the depression, but you're stifling the high points. The beauty of these medicines is that they're curative, and they enable you to experience life with all its beauty and all of its wonder. And hey, what a gift to give to somebody who's suffering.
Absolutely.
Yeah.
And we talk about access being, one of the primary concerns. Part of that access is price. And I'm just curious, how you see that panning out. We know that when medicinal cannabis opened up, it was highly expensive. At first, at least, the price has come down a lot. Still is prohibitive for a lot of people. But when we're talking about psilocybin and MDMA, how do you see that occurring, at least in this first instance, and then potentially down the road?
Yeah. Well, I mean, it's fair to say at the moment, sourcing medical grade psilocybin and MDMA is challenging because they've been prohibited drugs for a long time. What we've done is we've sourced medical grade psilocybin at very favorable rates from a North American supplier. Now, we can't bring it into Australia unless we get the right permits and licenses. But when we do, we'll be able to provide it to clinics and for trials and so forth at really in a very cost-effective way. MDMA, we've done a lot of work in terms of local production, again, to keep the costs down. But bear in mind, the big cost in all of this actually isn't the medicine, it's the therapeutic time.
Yes. Yeah.
The way I look at this thing is like, the costs of doing this are going to be higher than taking antidepressants because antidepressants are very cheap. But if you get well, there's a short-term significant cost, but you haven't got that enormous tail of mental illness that takes you decade after decade after decade.
For sure.
So if you do a net present value, these therapies actually are a lot cheaper.
And that's coming from a investment banker.
Yeah, coming from a
bit of
the net present value.
One of our ambitions.
Sorry.
One of our aims at Mind Medicine is to make sure these therapies are available to all Australians at prices that are affordable. So we're not doing this just to enable wealthy Australians to get therapy in Australia. Everything we do is focused on making sure that all Australians, wherever they live, whatever their financial circumstances, if they need these therapies and their psychiatrists believe these therapies are appropriate, we want to make sure they can be provided at prices that people can afford.
Does that mean that, like, for example, I think that there's current rules with Medicare where they will subsidize up to 10 sessions, I could have that wrong, per year for people seeking counseling or psychological services. Could you potentially see that, in the future, that these types of, and I don't know exactly how many sessions are required, but could that maybe fall under the banner of, subsidized, supervised clinical services?
Yeah, no, but potentially. And again, the aim is that bring it into the medical system, get the government comfortable with it and how effective it is in terms of cost, because you're getting people well, and then get to a stage where a very large proportion of the cost is subsidised under our medical system.
Yeah,
and that's got to be the ultimate aim. And the great thing there is that when you actually do the analysis, we think the government will save a huge amount of money.
Yeah,
because people will be getting well and out of the system.
Yeah, exactly. No, it's fantastic. Before we let you go, it would be remiss of us to skip a beat and not ask about or at least talk about the upcoming Mind Medicine Summit. For those who have an interest in psychedelic medicine, I think it's fair to say you've got the A-list of presenters coming.
Yep.
Rick Doblin, obvious head of the TGA, John Skerritt. We have Andrew Robb, I mentioned before, and a host of other people who have just dedicated so much of their lives to researching these medicines. I know it's being done virtually, but can you maybe give our audience just a bit of a flavor for what they might expect if they're thinking of picking up a ticket?
Yeah, well, it's going to be extraordinary because we really have got the leaders from around the world, from the research community and the scientific community, and leading people from Australia as well. I mean, basically what's going to happen is that each session is going to have a theme. Each session will involve 3 key speakers giving a short presentation. And then there's going to be discussion amongst the 3 speakers coordinated by the chair of that particular session. And then there's going to be Q&A, and it's designed to really tackle all of the key issues associated with bringing these therapies into our medical system. So it's designed for really the full gamut, from people in Australia who are in the health sector, who are people who are researchers, through to just people that are interested in these therapies and want to understand them. And interspersed with these sessions will be not only some amazing music and visuals, but also in the evenings, we're going to get some of the best psychedelic movies so that people can actually access them as well.
Brilliant.
And some of those movies are talking about new potential. So, for example, DMT and what happens to a person going through that experience. So it's really designed to bring this whole thing alive and enable people to really understand why it's so important that this country adopts these therapies and gets behind what we're trying to do.
Well, it's so exciting. And I think just the idea of, people who might be in a research silo or in a clinical silo, just having them all present their point of view and then having them on stage in front of the audience actually talk through and maybe actually learn a few things about, other parts of where these medicines might fit in. Conscious of time, and you've been so generous to give us so much of yours. Peter, thank you so much. Mitch, any other questions, or can we let Peter go?
We'll let Peter go. I just wanted to say, for those people out there listening or interested further to come down to the summit and things like that, how can people join the cause? Like what can people do? Is there anything that the average person?
The first thing is go onto our website, because there's a massive amount of information about these therapies, and there's great learn sections. You'll see the strength of our advisory panel and board. It's designed to be very user-friendly, and it's designed to cover the latest data coming out on these therapies from overseas and Australia. By going through the website, you can actually book your tickets for the summit, or if you're a practitioner, you can book to join one of our certificate courses in these therapies. We've also, by the way, got a new short course, which is 4 weeks for people who aren't necessarily practitioners but want to really understand how these therapies work. In terms of what you can do, you can join we have about 35 chapters around Australia, and our chapter network is growing very strongly. And that's part of a movement for change. And the role of these chapters is to really broaden understanding in their local communities about these therapies and the fact that they are supported by data and science. To talk to the local MPs, all that sort of stuff. Bring together like-minded people. So you can join one of those chapters. If you're able, you can donate to Mind Medicine Australia. Now, we are a charity. We can only function through donations and fees that we receive from courses that we run. So that would be something as well. But get involved, spread the word. Contact us if you have any questions. There's a contact section on the website. And just realize that actually we have a massive chance now to change the mental health paradigm and offer new treatments, which won't suit everybody, and we're not trying to suggest that, but will actually provide our medical practitioners and their patients with treatment-resistant conditions with a real opportunity to get well. And hey, wouldn't that be exciting?
Very exciting. And
on the precipice.
We are on the precipice, and it is a movement. And just huge credit to you and Tanya for getting it all started and taking the momentum forward. So we're very grateful to have your time. We look forward to speaking again soon, I hope, at some point. And Mitch and I are going to try and get along to the summit. So thanks so much, Peter. Really, really appreciate your time.
Yeah.
Okay, we'll keep spreading the word.
100% we will.
Okay, guys.
Thanks so much, Peter. Cheers.